Here's the last section of psych pathology before we come to pharmacology, and in my opinion it's the most fun. I've told you over and over again, while there are lists of intoxication and withdrawal effects, you can memorize those on your own time. I'm here to point out the important differences that will allow you to distinguish between these. And especially for the psychoactive drugs, identification is a huge part of what you're expected to do on Step 1 Psych. Now, arguably the most important recreational drug classes to know are the depressants and the stimulants, and really, it's not hard to tell them apart. Let's play a game called Stimulant or Depressant. Guy passed out on his friend's couch. Stimulant or depressant? Most likely, depressant. What about a guy running around like a maniac? Probably a stimulant. See? Not so hard. To be a little bit more scientific about this, depressants tend to cause anxiolysis and sedation, disinhibition, and at higher doses respiratory depression, whereas stimulants cause psychomotor agitation, weight loss, tachycardia, and at higher doses cardiac arrhythmia. Now, withdrawal symptoms tend to be the opposite of the actual effects of the drug. Now, why does that make sense? Well, when the receptors get routinely flooded like they do from an exogenous drug, the cells tend to both downregulate expression of that receptor on the cell's surface, as well as downregulate endogenous synthesis of the corresponding transmitter. But once the drug's gone, everything that was causing you to be happy and relaxed is now gone, and now you're cranky and on edge. Depressants, which do a nice job of making you chill and sleepy, have withdrawal symptoms that include anxiety, tremors, insomnia, and in some cases seizures. Stimulant withdrawal, on the other hand, causes depression, lethargy, and weight gain, as well as headaches. Some specifics about different kinds of depressants that are worth knowing. They all present kind of similarly during acute intoxication, with the exception being alcohol, which causes emotional lability as opposed to just mellowing you out. I'm sure many of you guys have experienced this firsthand. Opioid intoxication can be recognized by the pinpoint pupils, which is the single most distinguishing feature of the toxidrome. And finally, benzos and barbs look pretty much the same. You can test for acute alcohol intoxication with liver function markers. Since alcohol can wreak some serious havoc on hepatocytes even after one night of binge drinking, you can see elevated GGT or an AST greater than 2 times the ALT. Of course, in real life it makes more sense to check the blood alcohol, but come on guys, this is step 1. You have to know these trivial factoids so you can promptly forget them after the test is over. Of all the problems with depressant overdose, which do you think tends to be the most lethal? Without a doubt, the answer is respiratory depression. Benzos are the least guilty of it, though. Respiratory depression really only happens in mega high doses. By the way, this is why nobody uses barbiturates anymore, because they do pretty much the same thing as the benzos, but barbiturates are probably the worst offenders of respiratory collapse. Opioids are also pretty bad about this, by the way, but there's a pretty easy fix for this. Remember what it is? The answer is naloxone, a mu-opioid antagonist which will actually completely reverse the effects of acute opioid intoxication. Now, generally speaking, if you had to withdraw from a depressant or a stimulant, which would you pick? Well, aside from the fact that stimulants sound like they'd be way more fun than depressants, depressants also have way nastier withdrawal profiles. In fact, with the exception of opioid withdrawal, all of them can be lethal. Alcohol, barbs, and benzos are all GABAergic, meaning they act as anticonvulsants. Sure enough, in withdrawal, they can all cause seizures. Barbiturate and alcohol withdrawal can cause autonomic instability that can lead to complete cardiovascular collapse. And finally, severe alcohol withdrawal can cause a very specific constellation of symptoms called the delirium tremens, which we'll go over in more detail later. Now, because these withdrawals can be fatal, you can't just yank the drugs they've been using. You really need to taper these patients down. For all of these GABAergic drugs, benzos are used during detox because they're the safest when it comes to respiratory depression. Opioid withdrawal isn't fatal, but it really sucks. You should read through the symptoms yourself, but the ones that are the most specific to opioid withdrawal are goosebumps, which is where the term cold turkey comes from, dilated pupils, which makes sense, and uncontrollable yawning, which I always found kind of weird, but it's still memorable. It may not be life-threatening, but it's so unpleasant that most patients end up relapsing, and many more need long-term step-down or even lifetime support with methadone. They're still on opioids, but hey, it's better than shooting heroin. Stimulants are generally easier to remember than depressants. For one, amphetamine and cocaine pretty much present the same way. In addition to the typical stimulant profile, they'll also present with pupillary dilation and some slightly more manic features, such as grandiosity and psychosis. And if you've got a predisposition to psychosis already, congratulations! Either one can permanently push you into a psychotic disorder. The main difference is that amphetamines last for hours and cocaine lasts for minutes. So if somebody comes into the ED with these symptoms and they don't resolve even after a couple of hours, which one is it more likely to be? The answer is, of course, amphetamines. An overdose of either can lead to different varieties of badness. While both can lead to arrhythmias, cocaine has the nasty ability to vasoconstrict the hell out of your coronary vasculature, at best giving you a mild case of angina, at worst giving you a full-blown MI. Amphetamines tend to lead to arrhythmias most often, but can also cause seizures if you're predisposed to them. Complications of overdose in either are treated medically, but if you have a patient who's bouncing off the walls and nothing more, just tell them to simmer down and give them a benzo or two. With cocaine-induced vasospasm that causes angina or hypertension, the treatment of choice is an alpha-1 blocker. The worst thing you can do is to beta-block them, and why is that? Because beta-blockers will knock down your cardiac output at a time when your blood vessels are all squeezed as tight as possible, and that, my friends, is going to put you into heart failure. Now, caffeine's pretty lightweight when compared to these two bad boys, and the only really unique thing it does is cause diuresis. All these drugs have pretty similar withdrawal symptoms, and compared to the depressants, the withdrawal symptoms are pretty mild. Cocaine causes psychological craving, and all of them can cause you to crash and feel crummy, but there's no evidence that these build the kind of tolerance that the depressants do. Nicotine is a stimulant, but deserves a whole different discussion section. For one, its intoxication effects are very mild. The craving and anxiety caused by nicotine withdrawal, however, are arguably the strongest amongst the stimulants. For this reason, smoking is an extremely difficult habit to give up, and a number of products have been developed around smoking cessation. The one we all know is nicotine replacement, whether it's in a patch, gum, or e-cigarette. It's the patient's responsibility to taper down and can be effective, especially with the help of a primary care physician. The antidepressant bupropion and a partial nicotinic agonist called varenicline are drugs that have been approved for smoking cessation. Now, the rest of the drugs are all kind of categorized as hallucinogens, but really they're all extremely different. They're pretty much not even in the same category. We'll start off with LSD, which, in my opinion, is the only real hallucinogen on this list. Remember what type of hallucinations LSD tends to cause? Visual, remember? As opposed to psychosis, which usually produces auditory hallucinations. Even more than hallucinations, though, LSD produces perceptual distortion, and can also cause depersonalization, just as described in depersonalization disorder. The most fierce consequence of LSD is flashbacks, which isn't really a very well-studied phenomenon, so it's probably not going to be on your test. And unlike any of the other drugs on this list, LSD is neither habit-forming, nor does it have any withdrawal symptoms. Marijuana is one that more people are familiar with, either directly or indirectly, and really, I haven't seen a symptom list that does marijuana justice. Stoned is really the only appropriate adjective I have for marijuana intoxication. Sort of sleepy but silly, relaxed but sometimes prone to paranoia. Point is, there's a large cluster of possible symptoms, but the ones most specific to marijuana use are the red stoner eyes, increased appetite, or the munchies, and dry mouth. While it's true that nobody really overdoses on marijuana, you can actually get withdrawal effects from pot. Most of them are psychological side effects like irritability and depression, but anorexia and nausea are also common, which makes sense since marijuana is an appetite stimulant. On that note, while medical marijuana is not really mainstream enough to be high yield, it's worth knowing that synthetic cannabinoids are currently used as antiemetics and appetite stimulants in wasting diseases like cancer and AIDS. Finally, PCP. Scary drug, right? Alright, that's not what PCP users look like, but it's seriously what I imagine every time I think of one. Now here's why it's so scary. PCP combines the increased energy and stamina of a stimulant, but with a crazy belligerence that you don't really find in most stimulant drugs. On top of that, PCP is related to ketamine, so these people get weird dissociative hallucinations, and also feel no pain. Let me say that again, combining all these effects. You've guys who are tripping hard, want to punch everything in sight with their super strength and speed, and won't feel it if you hit them back. Now that's kind of scary. So, you may have to restrain him, but many of these guys will struggle so hard against the restraints that they dislocate joints and break bones. Now, other than these symptoms, what's the most reliable clinical sign to tell that someone's on PCP so you know when to break out the restraints? Just like ketamine, PCP causes nystagmus, which is a great code word for PCP on step 1. So, what's our plan for these guys, General? We don't want them breaking any bones if possible. The best solution is chemical restraint. That's really the way to go. knock them down with as many benzos and antipsychotics as they need, then give them supportive care as needed. Withdrawal symptoms are mostly psychological, but take it from me, withdrawal is really not the focus for Step 1's assessment of your PCP knowledge. Now, I realize I made it seem like opiates were the wimpy drugs amongst the depressants, what with its non-lethal withdrawal. Well, because Dare would get mad at me for not properly scaring you, here's a list of additional problems you can get strapped with if you happen to use heroin or really any drug intravenously. First of all, there's a ton of bloodborne pathogens you get from sharing needles. Now, which of the two ones we're most concerned with? Both hepatitis C and HIV have made it around the drug-abusing population. HIV is a transmission rate of about 0.3 per needle stick, but Hep C is a transmission rate of a whopping 33%. Remember, you always need to suspect these diseases in any IV drug user, and remember that HIV also has a lot of associated diseases. If you like, take a moment to glance at the section on HIV-associated diseases in microbiology. Second, I got a riddle for you. What wants to be inside you, but once you get poked, it's all over? Alright, let's not be gross, guys. The answer is Staph aureus, and to a lesser extent, Strep pyogenes. Healthcare workers wash their hands and use alcohol prep pads, but junkies don't tend to worry about that kind of thing when they're jonesing for a fix. The needles can track normal skin flora beneath the dermis and cause abscesses, or into the vasculature itself and cause bacteremia. And guess where Staph aureus ends up when it travels back through the venous circulation? You guessed it, straight back into the right heart, where it can cause right-sided endocarditis and even resulting pulmonary abscesses from the bacterial emboli coming off of the valves. Now, these sequelae are actually super high yield, so when you hear IV drug user, your mind needs to jump immediately to these possibilities for your differential. Now, on to beating an opioid addiction. Opioid addictions need a tapered dose to really beat successfully, but you can't exactly hand a junkie a pile of OxyContin and say, "Now be careful with these, you hear?" Methadone has gained popularity because it's a very long-acting opioid, so you can administer it from a clinic once a day, which works, but because the clinic has to be staffed with trained professionals, it's really resource-intensive. The way they tried to get around this is clever, in theory. Y'all know what naloxone is, as in Narcan? It's that drug that inhibits the opioid receptors and makes opioid addicts go straight from respiratory failure into withdrawal. Yeah, as it turns out, that's only effective when administered IV. It has no oral bioavailability. If you give people tablets of buprenorphine, a lower potency partial agonist, and naloxone, you've got dual protection from abuse. First of all, if you take it orally like you're supposed to, the buprenorphine will max out at a certain dose. It's nearly impossible to get lethally wasted on buprenorphine. And in case somebody tries to test that theory and inject the crushed up pill, the naloxone will become effective and not only block the buprenorphine, it'll also cause withdrawal as a deterrent. Turns out it doesn't quite work as well as people thought, but that's the theory anyhow. Finally, naltrexone is a weak opioid antagonist that can be taken PO, which makes its purpose totally different from that of naloxone. It's used more to prevent alcohol relapse, but also does kind of an okay job at preventing opioid relapse. The final thing we're going to discuss in this section is alcoholism, and this is a huge topic both from a medical and a psychiatric standpoint. We're going to go over a bit of both because this is again an extremely high-yield special population where you have to immediately look out for the common sequelae of alcoholism the moment you read 10 beers a day in the vignette. First of all, which organ is most characteristically damaged in an alcoholic patient? The liver, right? Even short-term binge drinking can lead to alcoholic hepatitis and fatty liver, but the really horrible and irreversible long-term complication is cirrhosis of the liver. The GI section will go into a lot more detail with that, but it's high yield enough that I think it's worth talking about briefly now. Cirrhosis accounts for a lot of the complications you see in patients, most of which stem from either decreased synthetic or metabolic hepatocyte activity, or from the portal hypertension that results from obstruction of the hepatic sinusoids. Second, alcohol is pretty toxic to the GI tract itself. It can cause both pancreatitis and gastritis. To add to the list of things that can make an alcoholic vomit blood, you also have the risk of Mallory-Weiss tears, which are basically partial thickness tears at the gastroesophageal junction, and of course, ruptured esophageal varices that arise from portal hypertension can also lead to an upper GI bleed. Now, how can you tell the difference between all these upper GI bleeds? We can sort of guess that a bleed that starts right after severe vomiting is probably a Mallory-Weiss tear, and that a life-threatening hemorrhage is probably from a ruptured varix, but really, the only way to conclusively tell is with an EGD, or upper endoscopy. Finally, alcohol can cause direct heart damage in the form of dilated cardiomyopathy and act as a neurotoxin through a variety of different methods, including hepatic encephalopathy via hyperammonemia, as we alluded to earlier. Two other important examples are caused by vitamin B1 deficiency and the resultant mammillary body destruction. Remember what those are called? The first one is called Wernicke's encephalopathy and results in confusion, ophthalmoplegia, and ataxia. Korsakoff psychosis is a psychiatric condition that comes from progressive damage. Remember, we went over this one in the amnesia section. With the talking Pac-Man heads? This is the most hilarious form of amnesia that results in confabulation. Now this one is treatable. Since the damage is caused by thiamine deficiency, you just need to give the patient B1. The syndrome for alcohol withdrawal is by far the most important one you need to be aware of, as it's not only very specific, but also very life-threatening, and they may not always tell you the guy's an alcoholic. In fact, the trickiest situation they'll routinely hand you is a guy admitted for surgery who starts freaking out a couple days after the operation. And you'll be putting on your doctor caps and going, was there a post-operative complication? And you'll totally be barking up the wrong tree. I'm telling you now, always keep alcohol withdrawal on your differential for patients who go south after a surgery. You're probably going to forget at some point, and then you'll be kicking yourself going, oh yeah, it's exactly like Arjun said, and then it will stick. Symptoms of time since the patient's last drink. The early symptoms are a lot like those of the other depressants. Remember what those are? They're anxiety, insomnia, nausea, and generally feeling horrible. The symptoms can progress to include confusion and tremors, and around 24 to 48 hours is where you have the greatest risk of seizures. It's also possible to hallucinate during this time, but I have to make one thing clear. Just because they're hallucinating doesn't mean they're having DTs. Alcoholic hallucinosis is a distinct condition where the hallucinations are pretty vivid, but the patients can generally understand that they're not real. These symptoms generally start to get better around the 2-day mark, but some of the patients progress to the delirium tremens. During DTs, the patients become even more confused to the point that the hallucinations are indistinguishable from reality, and they understandably get pretty upset about this. But the real thing that makes DTs so dangerous is that not only does the seizure risk keep rising as opposed to getting better, the patient's vitals become unstable, and they can become very febrile, hypertensive, and tachycardic. These patients need to be managed in an ICU, for sure. Like I said before, acute alcohol withdrawal needs to be treated with a benzodiazepine taper, usually a 5-day taper dose of a long-acting benzo like chlordiazepoxide. Unfortunately, for a lot of people, the road to recovery from what got them there in the first place is not so easily fixable. Long-term maintenance of alcoholism includes deterrents like disulfiram, which makes you violently ill if you drink alcohol, naltrexone and acamprosate, which help reduce the cravings. Oftentimes, group therapy like Alcoholics Anonymous is the most effective treatment for alcoholics, and the supportive network with an emphasis on mentorship helps keep the patients from relapsing. And that's it for Psych Pathology. Thanks for staying with me, and remember, drugs are bad, okay? Stay tuned for the pharmacology section, which is super high yield for psych, and if you like what you heard or want to comment on how awesome I am, use the thumbs up and comments box down below. Thanks for watching. Arjun Iyer, signing out.